I'm Dr. Shalini, consultant psychiatrist, Unarv Mind and Behavior Center. Today we are going to talk about sleep disorders. Sleep disorders is a very important part of the psychiatric model because people who do not get sleep cannot function normally. So coming to sleep disorders, what we talk about is non-rapid eye movement sleep, NRM sleep, as well as REM sleep, rapid eye movement sleep. Generally, REM sleep occurs 90 minutes after sleep onset. The slow wave sleep is usually NRM sleep, non-rapid eye movement sleep. That covers the maximum majority of sleep, whereas REM sleep comes in after that. And REM sleep is generally referred to as a paradoxical sleep. Pulse, respiration, temperature, blood pressure, all are increased during REM sleep. During NRM sleep, we have a sense of if there is any awakening during this period of slow wave sleep, there tends to be disorganization, and when arousal happens during that phase, there tends to be sleep terrors, nightmares, things like that usually happen during NRM sleep. And when coming to in REM sleep, we find there is a total partial erection that happens in males during this period, as well as there are other changes like dreaming. Dreaming generally is found during REM sleep. Although dreams during an NRM sleep do occur, they are not, as they are mostly lucid and purposeful dreams, whereas during REM sleep, dreams are more elaborate. And this happens during when we talk about REM sleep, it occupies almost 50% of the neonatal period of sleep, but it changes as it progresses. Generally, as the toddler grows up, it reduces to less than 40% of total sleep time. So when we divide the sleep stages, it's NRM sleep composes 75% of sleep, whereas REM sleep composes 25%. NRM sleep we generally divide into stage 1, 2, 3 and 4. So that that division happens as we take it as 45%, 12, 13% and eventually 25% for REM sleep. So when we divide the disorders that come under it, it first mention comes of is for insomnia, followed by hypersomnolence disorder, narcolepsy, parasomnias, circadian rhythm sleep disorders, as well as breathing related sleep disorders. We also have disorders, non-rapid eye movement disorders such as sleep terrors, sleep nightmares, the nightmare disorder. That all sleepwalking and sleep terrors comes under NRM group of disorders. And then non-rapid eye movement sleep behavior disorder, restless leg syndrome or restless movement based sleep disorder, as well as substance or medication induced sleep disorder. So coming to insomnia, insomnia is most predominant, occurs relatively commonly. If you look at the percentage in the population, it's from 30 to 45%. Insomnia is referred to as difficulty in initiating or maintaining sleep. Generally, that can be divided into persistent insomnia, partial insomnia, prolonged insomnia, as well as we say psychophysiological insomnia. So many of these, when you look at the reasons, it could be difficulty in initiating sleep. Like in some cases, sleep can be obtained when due to rumination or inability to fall asleep, could be due to excessive thinking or excessive concentration on sleep. Or they might be able to get sleep in a place away from their usual spot, like away from the bed while watching television, for example. And generally the usual center where you are sleeping might not induce sleep in that case. Then there are cases where sleep when you're unable to sleep because there is excessive thinking, excessive anxiety while going to sleep. When there is any other disorders involved, that also can contribute. Depression, low mood, all that can alter the sleep cycle. So this comes under insomnia. Insomnia generally we treat it with cognitive behavioral therapy. The distorted, disruptive thinking regarding or the excessive thought process regarding sleep, that distortion is corrected during cognitive behavior therapy, as well as universal sleep hygiene, things like hypnosis, sometimes progressive muscle relaxation, deep breathing exercises. All this contributes to a normal sleep pattern. Guided imagery, we say, we advise the patient to think of a happy place, or to have an image in mind as they're going to sleep, as well as deep breathing exercises, relaxing the entire body from head to toe for a few seconds, 5 seconds, and then alternating between relaxing and breathing. So that usually helps. And guided imagery, self-hypnosis, all this helps to a certain extent with correcting the insomnia. When coming to disorders like when we talk about hypersomnolence disorder, this is known as excessive sleepiness. Like it's normally due to maybe a neurological condition, maybe insufficient sleep. It can be due to cataplexy. Now, when we talk about cataplexy, it's sleep paralysis. So all these things can contribute, or a sudden onset of sleepiness. This excessive sleep usually has a reason behind it. There's probably a factor behind it, like neurological issues might be there. So excessive sleepiness should be corrected. We can usually use wakefulness promoting substances like modafinil, alpha adrenergic agonists, as well as certain drugs like SSRIs, tricyclic antidepressants. Some form of SSRIs do help. So generally hypersomnolence can be identified by the pattern in which the sleep occurs. Narcolepsy is similar, but it's an excessive or sudden sleepiness that occurs while doing a certain activity. Can be during eating, while talking, while driving, even while having sex. Even these things can happen. A sudden onset of sleepiness. So that is dangerous usually. It can lead to automobile or industrial accidents even. Generally, we have factors contributing to this. During this period, usually you find the hypnagogic, hypnopompic hallucinations, auditory and visual perceptual experiences that occur during this. It happens during periods of narcolepsy. Again, it can be corrected with these kind of procedures like universal sleep hygiene, trying to sleep at approximately same time every day. Modafinil, wakefulness promoting substances, generally helps with this. Chronotherapy also can help. The bright light therapy can also help to awaken the person. Then melatonin also has a role to play in sleep disorders as well. When coming to parasomnias, those are known as disorders of partial arousal. Again, in NRM sleep, you will find the sleepwalking, sleep terror kind of awakening periods, whereas in REM sleep, it is not as common. And disorders of partial arousal, the same applies. There is no sleep disorder. It cannot generally be monitored in sleep laboratories, but sleep studies can be conducted on this to find out a mode of treatment. Again, the actual underlying reason is the main what we mainly look for in disorders of partial arousal, or what is known as parasomnias. When coming to non-rapid eye movement sleep behavior disorders, a sleep walking type, what we call somnambulism. The patient might be doing actions or might be actively walking around. They might be, during sleep, they might be doing all this without their knowledge. But if they are awakened during that time, they might be suddenly confused or startled, and they would not know how to respond during that time. It's generally not very commonly seen in adult population, but 4 to 8 year age group, it is commonly it is seen. Somnambulism or sleepwalking type. Sleep terror type is sudden frightening panic attack while asleep. That occurs and the patient gets up in drench of sweat. They would be sweating while getting up, and it would be sudden onset. It would have occurred suddenly. It's known as pavor nocturnus or night terrors, parvor, incubus. These are some of the words to describe night terrors. They might not be nightmares that occur generally, but it might be a terrifying and brief static, terrifying images might occur during this period. Again, generally these kind of therapies, cognitive therapy, relaxation therapy, hypnotic therapies, all these help to bring these help with these conditions, along with some medications that are also given for this. Generally benzodiazepine group of medications, benzodiazepine hypnotic medicines are prescribed. Low dose, like short acting drugs are given for the difficulty in falling asleep, while middle of the night insomnia long acting medications such as diazepam are given. Zolpidem type of group of drugs are usually given for that difficulty in falling asleep. So they are short acting, so they do the job of people who have difficulty in immediately falling asleep. All these group of drugs, benzodiazepine receptor hypnotic group of drugs, generally help, opiates. And then coming to disorders, we talk about sleep terrors also, nightmare disorder. Sudden sudden onset occurs during NRM sleep mostly. REM sleep also it occurs. What happens is there are frightening images, so the patient is forced to lay awake. So it might be a long dream that suddenly turns into a nightmare, a long unending dream that suddenly becomes frightening, terrifying, and patients suddenly wake up with the knowledge they would have recalled some bit of it while waking up. So these are all conditions that generally occur in sleep disorders. We also have what is known as restless leg movement disorder, sleep disorders such as Ekbom syndrome. There is a sensation of ants crawling along the legs, or sensation of creepy crawly feeling on the legs while trying to fall asleep, on the lower limbs mostly. This generally what happens is the patient then tries to walk around, or tries to tries to increase the movement of the legs to calm the sudden anxiety or sudden feeling that arises in the legs. But what happens is a vicious cycle, because the patient will get up and walk around, and that contributes to the insomnia. So as the sleep pattern gets disrupted, so it persists and it becomes insomnia. Generally we give anti-epileptics, we give gabapentin form of medications, or benzodiazepines can be given in such cases. Non-pharmacological treatment includes massaging of the legs, hot showers, then hot and cold applied to the area, massaging the affected areas. All these helps to sleep as well. Restless leg syndrome, it's known as Ekbom syndrome as well. So this generally all these have a link with this insomnia. This contributes to the insomnia. It generally goes on to disturb the sleep. When we have sleep medication induced disorders, sleep medication behavior disorders, it can come from neural uptake, so it can be induced by some other moment, some other drugs that are given, some intake of drugs. All this can contribute to substance or medication induced sleep disorder. So again, we have to find out which was the drug that had been given, the underlying factor, which medication had contributed to this, and that medication then has to be tapered off or stopped or replaced with something else. Generally occurs with neural uptake or opiates, or that kind of excessive steroids, or those kind of long-term treatments. Generally you see these substance or medication induced movement disorders. Generally, sleep disorders are treatable. They are solvable just like most other psychiatric disorders, just that medical management and appropriate psychological management, psychological therapies have to be given in such cases. And main mode of management is to identification of the problem. Either the patient realizes it by himself or herself, or others are able to identify. In cases of sleepwalking and disorders like that, other people will be able to identify the family members. So it's important to bring them to us to rectify the situation as soon as possible. Thank you.